1, 2, 3, come on!
Hello guys, in this video we will discuss about the ventilatory parameters of a patient of the COVID-19. In the videos in the past we have discussed that whenever we admit the patient in a hospital who's suffering from the COVID-19, then there is a certain criteria of it. For example, if a patient has developed a severe disease of the COVID-19, wherein the patient develops a shortness of breath, a respiratory rate of more than 30, and saturation or the SPO2 falls less than 93% on the room air, and patient's PaO2 over FiO2 ratio, it goes less than 300, then patient fits the criteria to be admitted in a hospital. Now once these patients are in need of the supplemental oxygen, then initially we put these patients on these nasal cannulas. Now you can check here, it has got two nasal prongs and these are the tubings. So this is known as the low flow nasal cannula, where we can give oxygen flow rate up till 5 liters per minute. There are certain high flow nasal cannula which are preferred over over the non-invasive ventilation, and those high flow nasal cannula, which we also call HF and NC, can deliver oxygen flow rate of even up till 15 liters per minute. Now if a patient needs oxygen flow more than 5 liters per minute or around 10 to 12 liters per minute, then we have the option of a simple face mask, which is a rebreather face mask. So that will give oxygen flow which is higher than the nasal cannula. Now if patient saturation doesn't go higher than 92% on a face mask, or the PeO2 over FiO2 ratio drops even further, then we can switch the patient on the non-rebreather face mask. Now in the non-rebreather face mask, there is a bag which works as a reservoir, and patient can breathe oxygen from a high oxygen containing reservoir. And this non-rebreather face mask, it can given up till 15 liters per minute of oxygen, and as I already mentioned in a previous video, 1 liter of additional oxygen, 1 liter per minute, adds to 4% of FiO2, and on the room air it is only 21%. If we put the patient on a low flow nasal cannula, where we can go all the way up to the 5 liter per minute, then 5 into 4 will be 20% additional FiO2 on top of 21%. But in case of the face mask, we will be given 10 liter per minute, which is a rebreather face mask. It will be 40% additional FiO2 on top of the 21% of the room air. And lastly, in case of the non-rebreather, the FiO2 can go all the way up to the 60 to 80%. But if even in spite of giving these additional oxygen equipments, patient doesn't improve in terms of the saturation, and the respiratory rate remains on the higher side, and partial pressure of oxygen over FiO2 ratio remains less than 200, then we can put the patient on non-invasive ventilation, or the BiPAP, which is bi-level positive airway pressure ventilation. We can use ventilators for this purpose, and there are certain machines which are separately available. Now this is a BiPAP machine. It is connected with the humidifier, and we can put the patient with the help of this interface, which is naso-oral face mask. So in the world nowadays, the most important interface which is being used between the patient and the machine, it is the helmet, because helmet helps to decrease or minimize the transmission of the coronavirus from the patient to the professionals and the healthcare workers who have surrounded the patient in order to manage the patient. Now if the patient is not either tolerating the BiPAP or the non-invasive ventilation, or patient deteriorates, and the parameters which I just mentioned, the respiratory rate, PaO2 or FiO2 ratio, and saturation of the oxygen in the body, which we detect using the digital pulse oximetry, which we also call the SpO2. Then we put the patient on the mechanical ventilators, and in order to put the patient on the mechanical ventilators, we need two very important things. One is this one. This is known as the endotracheal tube. Now this endotracheal tube has got some parts. For example, this one is the balloon of the endotracheal tube. Now This is the pilot balloon. This one is the balloon, and there is a line or pipe coming all the way up till here, and then it comes out. And here we have the pilot balloon. It has got a lower lock where we can inject the air. So we'll just fix it and we can inject some air. The idea is to put in as much air as is the number of the tube. For example, if this is 7.5, which is the internal diameter of the tube, then I'm gonna inject 7.5 ml of the air. Now this balloon is now inflated. We can check its patency. What is the role of this balloon? It won't let the secretion go down, and it will also avoid any leakage from the airway to the outside. So it is a high volume, low pressure cuff endotracheal tube. So after we have checked the patency, we can deflate it, because we did it for the purposes of the just demonstration. Now this tube has got here, these are the Murphy eyes. Now this is from where you can put the air from the ventilator all the way down to the lungs. So this is a Murphy eyes. It not only helps to put the air in, including oxygen and the air, but it also helps to take out the secretion using this endotracheal tube. Now there are certain graduations. If you can see, these are located here. Here is the 7.5 is the ID. ID is the internal diameter. Then there are certain gradings in centimeters. So normally in female, we place it at 21 centimeter, and in the male we place the tube on the incisor teeth at 22 centimeters. So other than this is the connector, which is 15 millimeter, and here we attach the oxygen source. So this is endotracheal tube, which can be used orally or nasally, and obviously when we pass it through the nose, we need to pass it even further, but taking care that it doesn't go past the carina, which is the bifurcation of the trachea, because in that case it will only inflate right side of the lungs and the left will collapse, or there will be atelectasis. So we need to check it on the X-ray and also by auscultating 5 regions, which I'll mention later on. So this is known as the endotracheal tube. This is what we to begin with, we use it to put the patient on the ventilator, and if any patient needs mechanical ventilation for more than 2 weeks, then we switch this to the tracheostomy tube. So that is sort of a tube which is shorter in size, has got almost same internal diameter, and it stays there for longer period of time. And if we are to use the endotracheal tube for more than 2 weeks, then there is a risk of developing a fistula or abnormal communication between the trachea and esophagus. So we want to avoid it. So if you notice, this is a very flexible tube. So whenever you are passing it after applying gel on this part of it, there is a chance that it will just have a kink. So in order to keep it straight, we use this stellate, which has got 2 ends. So we take care not to let it pass beyond the Murphy eyes. We just keep it before that, so it doesn't damage the trachea. Now it will keep the endotracheal tube straight rather than being very much flexible. So having a stellate is very important in order to pass the endotracheal tube. Also, if there is a problem in passing the endotracheal tube to the patient, another thing which can help us is known as the bougie. Now this bougie is just like the endotracheal tube. It is lengthier in size, and it has got certain gradings in centimeters. Now it has 2 ends. One is more pointed and one is has got a bend, which is the safer side. So you can, with the help of the laryngoscope, which I'm gonna demonstrate in a while, you can look at the trachea. Then you can under the VN you can pass this bougie in the trachea, and you can go a little bit lower than that. Then you will have to hold it this way, and using the Seldinger technique, you can pass the endotracheal tube through it all the way down to the patient, and then you can, once it is going there, you can remove the bougie. So this helps in difficult cases, and the technique which we use is known as the Seldinger technique, which we also use when we are passing the central lines or the triple lumen and the double lumen lines. Once you have passed the endotracheal tube and it goes like when you are passing it, you pass the endotracheal tube by looking at the opening of the trachea, and you need to enter the endotracheal tube while you are visually watching it. You are actually having a look at the opening of the trachea. You will see that it is going inside the trachea past the vocal cords. Once it is gone past the vocal cords, you are in a safer zone to inflate the balloon, so try to note that part. So this will help you fix the centimeters point on the incisor for each patient. So this is very important. Once you have passed it and you are sure that it is not below the carina, then you need to auscultate on 5 points. You can auscultate on the upper part of the right and left chest, on the lower part of the right and left chest, and in the epigastric area. You shouldn't feel any auscultation on the epigastric area, but both on the right and left side. If it is on the left side, right side, and no auscultation or no finding on auscultation on the left side, you better pull the tube a little back, because this way it will be coming 2 to 3 centimeter higher than the carina. Otherwise, if you don't do it, it will only inflate the right side of the lung rather than the left side. So there will be a lung collapse, because if you notice from the anatomical point of view, carina, at the level of the carina, trachea subdivides into 2 bronchioles. Now the right side is straighter one, and on the left side there is a bend. So whenever you pass the endotracheal tube beyond certain point, it will definitely go towards the right side, so avoid it. Now we pass the endotracheal tube with the help of laryngoscope. Laryngo mean larynx, scope mean visualization. So this is the laryngoscope. It has got 2 parts. One is, this is known as the handle, and this is known as the handle, and this is the blade of the laryngoscope. You can just attach it and detach it. Why we need to attach it? There is a light source, if you can see it here, and there is a connection point for the light source. We just approximate them this way. We are to just approximate, click it, and just snap it back. So this light source, it becomes then, here you can see, but if I disconnect it, you will see the light going off. So there is a light source in the handle, and you need it to come through the bulb. So here it comes. This is the direction of the light source, and this is how you apply it. You just hold it in your left hand, holding the blade in the right hand. You approximate these two, and then you snap it this way. So whenever you are to pass the endotracheal tube and you have actually looking at the tracheal opening, you just slide it along this part of the endotracheal tube, and it will go all the way down, because you hold the endotracheal tube in your left arm like this. Okay, you pull the pressure forward way, and then you also pull the tongue on the left side. You by looking at the tracheal opening, you just go inside the trachea, and once you are there, you will remove the stellate. Now once we have put the patient on the ventilator by inserting the endotracheal tube, and we connect the ventilator circuit with the help of the connector portion of the endotracheal tube, then what are the parameters of the ventilator? The first and the foremost is the mode. Mode will tell you which way you want the patient to ventilate. Our main purpose of ventilating the patient in the case of the COVID-19 will be the hypoxemia or type 1 respiratory failure, where patient's partial pressure of oxygen is less than 55 millimeter of the mercury. Then the other purpose of the ventilator is to remove the carbon dioxide. It sends in the oxygen. Then at the level of the alveoli, there is a diffusion of oxygen from the ventilator side to the inside of the body, and from inside the body, from the capillary side, comes the carbon dioxide, which diffuses inside the alveoli, and the ventilator during the expiration removes it. Mode tells you which way you want to give the patient a breath. There is always a controlled mechanical ventilation in case of the COVID-19 patient, because they have developed either widespread pneumonia or ARDS. So the most important mode of mechanical ventilation in these patients will be the assist control, volume control ventilation. In this type of the ventilation, the control of the tidal volume, which is the volume of the air which we take in or out with every single breath will be with the machine. Though the patient will have the option of triggering the machine using the flow of pressure of -2 or a flow of 5 centimeter of the water, but a backup rate will be given by the machine. For example, if we have set the tidal volume of the 500 mils per minute per breath, the tidal volume will be set according to the 6 to 8 ml per ideal body weight. Now, the Assisst control, volume control ventilation, a set tidal volume will be given each number of the time which we have set as a respiratory rate. The pressure in the circuit or the pressure will keep on changing according to the resistance of the airway and compliance of the lungs and the chest, but tidal volume will remain the same. It is a volume assured way of ventilating. For example, if based on the lung protective strategy, patient's body weight is say 500 kilogram is the ideal body weight. We'll multiply it with the 7, which is the average of 6 to 8 ml per kg, and the answer will be 350 ml will be the tidal volume, and we want to ventilate the patient in a way that we sort of set like a respiratory rate of 17 breaths per minute, because at the end of the 1 hour or 30 minutes we will get the arterial blood gas analysis, and then we can adjust the rate and the tidal volume. So in the volume control, which is a Assisst control volume control mode of ventilation, we have got option of controlling the tidal volume and respiratory rate, but pressure will keep on changing according to the lung and airway mechanics. Now another thing which we are to make sure that we also set the FiO2 or the fraction of inspired oxygen. Room air is the 21%. We try to use the nasal cannula which took it up to like 40%. Then we use the non-rebreather mask and the high flow nasal cannulas to make it around 60 to 80%. But here on the ventilator we have the option of using the 100% FiO2 according to our patient's parameters. Like if a patient saturation is even lower, we can keep it 100% for some time. So up till now we have set tidal volume, respiratory rate and FiO2 or fraction of the inspired oxygen. Another very important parameter which we set in these patients of the ARDS, which so many of these COVID-19 patients develop, is the PEEP or the positive end-expiratory pressure. Now at the end of the every inspiration there will be expiration. When the expiration is taking out the breath, then there is a chance that because in ARDS patient there is an interstitial fluid, the alveoli can collapse. So we want the alveoli to remain patent even at the end of the expiration, and we use the pressure which we call the positive end expiratory pressure, which recruits these alveoli which have the risk of being collapsed. So it prevents the atelectasis, it recruits, it decreases the shunting effect on the lungs and the alveoli. So we can use an PEEP of like 5 to 15. The range will be 8 to 10 or 10 to 12 centimeter of water is the PEEP pressure which we use in these patients. But there are certain situations there where we don't have because we are to avoid complication of the ventilator. What are those complications? Those are the barotrauma and the volume trauma. The barotrauma can be reduced by keeping the plateau pressure less than 30 centimeter of the water. Now plateau pressure is the pressure in the alveoli, which is sort of equivalent of alveolar pressure, and we check it on the ventilator by using the inspiratory hold button. We want the flow to stop, because in case of the volume control ventilation there will be an accelerating phase of the flow, and we want the flow to stop altogether so that we can measure the pressure in the alveoli, and that is the plateau pressure. So we all this time we will make one thing sure, that the plateau pressure doesn't go higher than 30 centimeter of the water. This way we can avoid the barotrauma, and we are already following the lung protective strategy where we use the low tidal volume 6 to 8 ml per kg ideal body weight to avoid the volutrauma. But if all those cases where it is very difficult to keep the plateau pressure even less than 30 centimeter of the water, another mode of the ventilation is the pressure control. In the pressure control mode of ventilation, we have got a control over the pressure or peak inspiratory pressure which is in the airway and the lungs, but volume tidal volume will keep on changing according to the situation in the lungs. If the lungs are very compliant, if there is no airway resistance, then even a smaller PEEP or the peak inspiratory pressure will generate a high tidal volume. But if the lungs are very non-compliant, then a higher peak inspiratory pressure of say 30 centimeter of the water will only be generating a tidal volume of around 250 mils per breath. So because from the mathematical point of view, compliance is equal to change in the tidal volume divided by change in the pressure. So there is an inverse correlation of the compliance with these two parameters. So this is very important that we remember this thing. Now, in order to increase the lung compliance or decrease the plateau pressure, we can also use certain maneuvers, like we need to keep the patient sedated, and we can also use the paralytics in most of the time if the patient has got the asynchrony or dysynchrony with the ventilator. We also keep the patient in the prone position for 16 to 18 hours a day in order to recruit the lung bases or the posterior part of the lungs. That will also help us decrease the plateau pressure. And at the end of half hour to 1 hour, whenever we are making changes in the ventilator settings, we better get ABGs so that we can keep the pH above 7.25. We can keep the PCO2 around 35 to 40 millimeter of the mercury. We can keep the PO2 above 60 millimeter of the mercury, and we are also following the bicarbonate or lactate level to see the metabolic status of the patient. So if a patient just keeps on being on these either of the two, and in most of the cases we use the volume control ventilation. We can also just maneuver the IE ratio, which is the inspiratory to expiratory ratio, by changing the flow rate. If we flow rate will tell us if we want to give in breath very rapidly, we will increase the flow rate and our expiration will be prolonged and we can get rid of the carbon dioxide. But if the problem is with the oxygen, if the patient has got type 1 respiratory failure or hypoxemic respiratory failure, then we will require the inspiratory flow rate to be slow, so that a larger portion of the breath should be given to the inspiratory phase and a smaller to the expiratory phase. So we keep the IE ratio 1 to 1, or we can inverse it. In that case, inspiratory will be 2 and expiratory will be 1. And how we achieve it? By decreasing the flow rate. That largely depends upon how your patient responds once patient is on the mechanical ventilator. So on an average, these COVID-19 patients remain on the ventilator for a couple of weeks, and then we decide if they are doing fine, then we can just switch it back. These patients also, if there is no contraindication, these patients will need anticoagulation prophylaxis. These we need to take a very good care of their caloric requirement, because they may be in the negative nitrogen balance status. And if patient doesn't improve even on being on the ventilator, then unfortunately we will have to go for the ECMO, which is the extracorporeal membrane oxygenation, wherein we use the machine like the hemodialysis machine. That machine will take some blood from the body, will add in oxygen and will remove the carbon dioxide from the body and then send the blood back to the body. So from the blood, machine adds the oxygen, and from the blood it removes the carbon dioxide, and this oxygenated blood is sent back to the body. It works more or less on the pattern of the hemodialysis machine. If patient being on the ventilator, they develop hypotension as a result of PEEP, and patient is hemodynamically unstable, then we can add the inotropic support and the vasopressor support. Vasopressor support is the noradrenaline, and inotropic support is the Dobutrix, dobutamine, and the dopamine. We try to keep these patients in the negative balance from fluid point of view, because the studies have shown that those patients who have been in a positive fluid balance, they are not doing as good as those who are in the negative balance. Sometimes we need to use diuretics in these patients. We can also use steroids like methylprednisolone in these patients, 40 milligram twice a day if there is no contraindication. That will also help these patients, especially if they are in severe septic shock. And as a result of the this infection, patient can also develop renal shutdown. In that case, we will need CRRT continuous renal replacement therapy, or CRRT. So these are the basic parameters of the ventilatory management. Just revising it back, the best mode is the assist control, volume control. Try to keep tidal volume on the lower side, which will be 6 to 8 ml per kg, and if we are to get rid of carbon dioxide and tidal volume, we are to keep it on the lower side, then we can increase the respiratory rate. We'll make it like 12, 17, 20, 23, we can into 30, we can escalate the tidal respiratory rate, because our studies show that a minute ventilation is the combination of the tidal volume and the respiratory rate, and a minute ventilation is the volume of the air which we take in and out each minute. So we can get rid of the carbon dioxide even by increasing the respiratory rate rather than the tidal volume. So we are to set the mode. We are to set FiO2 initially on the higher side, then we can decrease it with the help of the PEEP, and the target will be to keep it less than 60%, because that will help us prevent the oxygen toxicity to the lungs, which can deteriorate the lesion on the lungs and the CT scan further. So mode, tidal volume, FiO2, respiratory rate, flow rate, IE ratio, PEEP, and flow rate we had already said. So these are the major and last and very important thing. We are to set the trigger sensitivity of the ventilator. It may be -2 centimeter of the pressure, and it can be 5 liter per minute flow. So whenever the patient is in need of another additional breath, patient can just trigger the vent, and the ventilator will give an additional breath of the tidal volume which we have set on the ventilator. So that is a brief introduction of the ventilatory parameters in case of those patients who are suffering from the COVID-19 and they ultimately end up on the ventilator. Thanks for watching the video.